bringing your shoulder to the wheel for this ever so important cause. And just to put in context the importance of what you are doing, every day in California, we lose 212 people to heart attacks and strokes. Just to put in context of these incredibly devastating fires that we're dealing with, where we now have a, just a brutal death count, but it doesn't compare to what we're losing here from heart attacks and strokes. So just to motivate you all, think about the fact that by your dedication to applying our now very substantial science for reducing heart attacks and strokes, where we have shown in our first pilot community that we were able to drop heart attacks, hospitalizations by 3,826 over 6 years, which was a 24% decline in the first 4 years, sustained at 22%. So we know that by applying the basic science, we can rapidly reduce heart attacks and strokes. And I just we so appreciate the level of dedication in this room. We've had people fly in from San Diego, Los Angeles,
Dubai,
Afghanistan. Dr. Joe Sky, would you please stand up so we can give you a round of applause? Joe is the head of cardiovascular for Travis Air Force Base, and he's just finished service in Afghanistan, and we are so grateful that his very first day back at work, where is he? He's with us. Thank you, Joe.
Fantastic. I'd like to get started with just some overview, some slides, some metrics that we can now digest from the last year and the previous years up to there, and that will kind of get us kicked off before we hear Dr. Robinson and Dr. Flinn and Dr. Shahdadpuri. And Brian's going to take over the slides and get us rolling. And we have on the line, I think,
From New York.
I've heard that before. Dr. Bill Baumer. Bill, can you hear us? We can't hear you. I don't know if you can hear us.
So Brian, would you text back and
Hang on,
forth?
I'm taking it off mute.
Back off.
Well, we're glad that you are with us, Bill, and we can hear you loud and clear now. Thank you.
And welcome to Dr. Shahdadpuri's father, who's joined us, taking the long session to join us.
That tells you something. She had her father come from across the world, and yet she made the time still to come and join us. That's wonderful. And brought him with you. That's great. Okay, so initially we're going to look at some medical group data from our area, the commercial HMO plan members. This report card is from 2000 and just the last three, that PY is performance year. And that just gives us a bit of an overview, first slide being on hypertension, of where some of our plans, how we're doing. And I really wanted to highlight, too bad we don't have Jose here, Dr. Arevalo from Sutter, IPA, but Sutter, just highlight those areas of the graph that showed significant bumps up over the last couple of years. And if he were here, I'd tell him, how did you do that? But I think he's just continuing on the great work from when he was a chair here at the RightCare initiative. And next, similarly, hypertension in our diabetics. Again, you can look at the various plans and see where we've gone, and again, a little bit of bump up there with Sutter, and finally, well, not finally, but then we've got our diabetes measurements. Again, hemoglobin A1C less than 8 is the measure on this one. So, we've had some ups in some areas, and some of those areas where we were really making some great strides in the blood pressure arena, maybe we didn't quite get the same success in controlling our diabetes, and things kind of bump up and down. I think what's important is where we do have some outliers, we can say, okay, what was working, especially, where we've seen some real positive gains. What is it that may have contributed to that? And some of our speakers today will probably speak, they will be talking about their efforts in this. And then California health plans. These are some of our, these are kind of busy slides, so you can look at, and I don't know if you can even see it from where you are. I almost need my glasses from, I've got it right in front of me, that's beautiful. Again, you can see some trends. You can look at where you're interested in. Initially, again, we're going on our hypertension and our diabetes stats and the various plans that have had some great success. Some that haven't seen a lot of change in trends over the years. Some that kind of dropped down. And so as we look at this, then we can determine again why are we having success, why are we not having success, and then the percent change, whether that may be a little bit small, it's probably much too small for you to see. Blue Cross, the second one there showed an increase in 12% from the 2006 to the 2017. And a few other plans were tens in those kinds of numbers, and then a few that had some downward trends for various reasons. So I think it's wonderful. We're not seeing just crazy success everywhere, or even in one place, but there are some places that have been strong for lots of years, and some that have made some upward movement. You can see as Sharp kind of had some persistent upward movement there in that purple line that's now above that national 90th percentile. And if you have, Hattie, if you have anything that you can share that would add to this, then please. We'll head. So the next one is with both. So again, the diabetes and our diabetics with the blood pressure control.
The one thing that I do want to add is just that our small regional plans that have closer relationships with the medical groups tend to do a little bit better. So I want to call out Don Hufford. Please raise your hand. And perhaps you can shed a little bit of light about how that works during our discussion period. But I want to also just commend Dr. Hufford for his very substantial quality improvement efforts at Western Health Advantage, where you see them nudging up to the 90th percentile there in this very important metric. So you have our two regional health plans, both Western Health Advantage and Sharp, doing very well relative to the larger network model plans. And of course, Kaiser, who we'll be hearing from, we're actually going to shift the agenda a little bit to say that, they are #1 in hypertension control in California. We're going to hear from them first. We're going to shift the agenda just a little bit. We have Dr. Kristen Robinson with us to share their very important methodology for how they're leading us in improving hypertension. So the other thing I would just say is that it is such a challenge for the large network model health plans to be able to corral the data because frankly the data is a roll-up of what all the different medical groups are doing. And so, and actually, Brian, would you mind bringing the microphone to Don Hufford so he can talk a little bit about how it is a bit easier for the local health plans with their strong connections to be able to drive the numbers on these important metrics. Thanks, Don. Our first co-chair of this group. Thank you for launching us.
Can you hear me okay?
I'm not sure if that's on. Brian, does it look like it's on?
Okay. I don't think it's anything magical. It's just we only have 6 medical groups that we're contracted with, and most of them are large and sophisticated and have infrastructure to support the physicians. So really, the action's happening at the medical group level. We do share best practice ideas at our QI committee amongst the medical leadership. But other than that, that's largely it. It really depends on the infrastructure that the medical groups have behind them. Electronic medical records and being able to identify those people at the medical group level. That's really where the change is going to happen. There's patients listed much more than the physicians and the physician groups than they do the health plans.
And do you also give financial incentives to achieve your key metrics?
We're in the pay-for-performance program, and so that's part of it. But, you know, we're in that along with all the other health plans in California. So there's a good incentive there.
Great. We'll commend you on your progress. Thank you.
I was stuck on the second to last slide. Here's the last slide. So this is the California plans, large plan, all from 12 to 17, A1C. So I think that's something that's important for all of us. And as a family physician, I know how important it is that it really comes down to me. I do also know that the tools that I'm given and the motivation that I'm given and the various, the electronic record you mentioned that I leverage then and my staff leverages can be really important if you've got strong leadership in the group that can make that all happen. Okay, well there we go. So, thank you very much. Again, Dr. Robinson will be our lead speaker here, Chief of Chronic Conditions Management for Kaiser. And she's an internist. We've got an internist, a pediatrician, and a family physician today, so it's a great mix. I really like it. As you look across, I don't know how many of you have the bios, but all of them have fantastic bios, and Kristen, or Dr. Robinson, sorry, has had a lot of great experience in the quality arena, and I couldn't help but also notice that you majored in microbiology and German, and I'm a German speaker, so that was great. We can maybe speak a little later about that. And we graduated from medical school in the same year. Strong work. Okay, so I'll turn the time over to you, Dr. Robinson.
Hi, I'm here representing Kaiser in the Sacramento-Roseville area. I'm the Chief of Chronic Conditions Management, and I also have a lot of experience in the administrative roles at Kaiser over the years as a modulator and also as an Assistant Chief of Medicine at Kaiser. So, disclosure, I don't have any financial relationships or commercial interests. So I wanted to first start with a discussion about Kaiser in Sacramento in general. So Kaiser in Sacramento covers multiple counties, a very large geographic area. It covers Sacramento, parts of Yolo, El Dorado, Amador, Sutter, and Yuba counties. We have patients coming from Oroville all the way down to Lodi, Galt, and then all the way over to Placerville. The North Valley is considered sort of the Sacramento-Roseville area. That's the area that I represent. And that's Davis, Rancho Cordova, Central Sacramento, Roseville, Lincoln, Folsom. And South Sacramento is actually more the Florin area, Elk Grove, the Laguna area. So when we talk about Kaiser and Sacramento, there's actually two different area groups that work differently and are function separately. So in the greater Sacramento area, we currently have 873,000 patients. And in the North Valley, that's the bulk of it. It's 666,000 patients currently and growing every year. We have, in the North Valley, in the Roseville, Sacramento area, we have 1,200 physicians, and almost 300 of those are primary care adult medicine or a family medicine physician. So it's a very, very large group to work with. So I just wanted to comment a little bit on our hypertension journey and where we've been and where we hope to go. So historically, our performance was around 52% back in 2005. And we recognize the need to improve that dramatically. Our goal is currently 90%, Other Northern California sites at Kaiser are at the 90% level, and some are even higher. Currently, our performance is around 84% cumulatively for our entire adult population. It ranges from about 82% in Sacramento, that's our lowest area, which is the more urban area. And in our some of our outlying suburbs like Lincoln, Davis is also quite high. It's around 90%. So when we look at our diabetes populations, we also put them into higher risk subpopulations, including our diabetes population, our African American population, and then we have a population called FACE, which means preventing heart attacks and strokes every day. Our FACE population is a group of patients from 18 to 75 that have population management, and those are patients who have diabetes or atherosclerotic coronary vascular disease. They've had a stroke or a heart attack, documented carotid artery stenosis, or documented peripheral vascular disease. So those are patients that we recognize have a higher risk of complications from hypertension, and we have a group of pharmacists and nurses that work aggressively with that population. So one of the big focuses we have is to focus on the why. Why are we so concerned about blood pressure, and why is this so important for us to treat it? Well, and I particularly like this slide because the graphic is so powerful. So we can reduce the risk of congestive heart failure by 50% by controlling blood pressure. Heart attacks and strokes can be reduced by 20 to 25%. I'm sorry, heart attacks 20 to 25% and strokes 35 to 40%. Those are amazing statistics. And when you look at how much does a primary care doctor need to do to make an impact on somebody's life, it's even more powerful. Think about how many mammograms do you have to order in order to save one life. It's in the hundreds. When you look at how many patients you need to treat for blood pressure, to control their blood pressure to save a life or to prevent a catastrophic cardiovascular event, you're looking at maybe 10 to 11 patients for people in the lowest risk categories. When you start to look at patients in the higher risk categories, patients with diabetes, patients who smoke, people who've already had an event, the rate is even high, it's even lower than that. You probably only need to treat 5 or 6 patients in the higher risk categories. So focusing on the why and letting people know that you only have to treat 5 or 6 or 10 to 11 patients, 5 to 10 patients, to make an impact on somebody's life. That's a pretty powerful message. So focusing more on what our strategies are for improving our blood pressure control. The first thing we like to talk about is what we call in-reach. So what do we do with the patient when they're in our office? So one of our mantras is every patient, every time. Every time a patient comes in, we review the blood, we have the medical assistant check the blood pressure, and we review the correct position with them. If it's high, they automatically get a second blood pressure, and then we use automated blood pressure machines in specific circumstances. If the blood pressure is elevated, the medical assistant automatically books them a follow-up appointment, either at a blood pressure screening station or at a free blood pressure recheck appointment in our office. So that's automatically done before I even walk in the room. The MA has already checked it twice, and if it's still high, they automatically book a second blood pressure follow-up within 2 weeks. So, and then the primary care doctor is tasked with checking or addressing the blood pressure during the appointment, adjusting the medication, reinforcing medication adherence, or whatever is appropriate in that instance. So I wanted to talk a little bit about automated office blood pressure machines. I'm not sure how much everybody is using this. We've just started using it at our office to great effect. So what this does is basically the patient sits in a quiet room for 15 minutes, and they get 3 readings at 5-minute intervals. So they get 3 blood pressure readings that are unobserved. The staff preps the patient, puts them in the right position, asks them just to be still and quiet for 15 minutes, and the readings and averages are displayed on the advice. The target blood pressure using that machine is often 5 points lower than the target blood pressure using conventional office readings. And anecdotally, about 50% of our patients who have high blood pressures when they come in, if we use the automated BP machine, it comes down to the normal range. So when we looked at the study for using automated blood pressure machines, if you look at the different numbers, these are 3 different studies. The routine machines were these were all elevated to start with, and then using the automated blood pressure machines, it came down dramatically, especially here, 132/75 came down 20 points, and it was equivalent to what they found with the awake ambulatory BP. So we think that the automated office blood pressure is a more accurate reflection of what patients' true ambulatory blood pressures are. Okay, so when the patient comes back for a blood pressure recheck, we have two different options for them. The first is our blood pressure screening stations. They're all staffed by medical assistants. They're available at all of our sites. During normal business hours, people can either have an appointment or they can walk in. The chart, once the blood pressure is checked, if it's normal, you're good to go. If it's high, the charts are sent to the primary care doctor to adjust the medication. If the patient doesn't show up for one of their appointments, the physician is notified to have that rescheduled. If it's dangerously elevated, if it's above 100, if I think it's 180/110, or the patient's having problems or symptoms, we actually send them to the nearest medicine clinic where they're assessed by a nurse and a physician. If the patient is in this phase, population care program, it's sent to the pharmacist to have the medication adjusted. So there's always a follow-up link once the patient gets the blood pressure rechecked. The other option is...
Could you say a little bit more about that pharmacist phase program?
So we have a group of about 32 pharmacists, and I think we have 3 nurses right now that work with our diabetic population and our phase population. And it's mostly focused on patients with a A1C, a hemoglobin A1C of greater than 8. That's really the driver for it. But they also do outreach for statin adherence and statin fills. And then we also have them help us with the blood pressure control too for this population. We have a very extensive aftermarket product called Prompt that we use. It stands for Patient Reminder, Outpatient Management, Patient Reminder, Outreach Management, and Population Tracker. So it's a comprehensive program that can be used for the pharmacists and the physicians to see which of their patients are not in control, which patients need to be on a statin, who needs mammograms, who needs pap smears. It's very robust, and it's used with our Epic system. I couldn't bring you a slide about it, but yes, it's a very helpful tool, and you can just we can pull up our lists anytime we want to see, for example, which of my patients need to be on cholesterol medication, who have atherosclerotic coronary vascular disease. So with our blood pressure appointments, they're offered free of charge at all of our clinics. If the patient's normal, they're discharged. If it's high, the primary care doctor intervenes right away and adjusts the medication, directs the patient for follow-up appointments and labs. And we also have weekend appointments available at our after-hours clinic. So if a patient says, I just can't come during the week, we can book them on a Saturday and they can come get their blood pressure rechecked. So for medication management, I think we follow pretty standard protocols. We have a very standard set of recommendations. We start with an ACE or an ARB with a diuretic, generally speaking. Another option is to start with a calcium channel blocker or to add that at step 2. The third step we do is we add spironolactone. If the patient is already on a thiazide diuretic, their GFR is greater than 60, so they don't have chronic kidney disease, and the potassium is less than 4.5, we recommend putting them on low-dose spironolactone and monitoring their labs and their blood pressure. So if they're not eligible for spironolactone, we could consider a beta blocker and some of the other centrally acting agents, but that's the general protocol we use. I'd say probably the vast majority of our patients get under control, maximizing step 1 and step 2, and it's a very small number that actually need to go to spironolactone or beta blocker. So another key piece to our success is subspecialty care. And one of our mantra is that quality is everybody's business and everybody participates and everyone benefits. So this is done mostly through back office action by the medical assistant, reminders, and appointments. When a patient comes into Kaiser for subspecialty care, the medical assistant checks the blood pressure. reviews the prompt screen to see if they're due for any labs. We also look at cancer screening and immunization. So for example, I went to see a physical therapist recently, and they told me I was due for one of my cancer screening tests at physical therapy. Another one of my patients, we've also included that in our flu clinic. So when they go get their flu shot, we tell them if they're due for cancer screening, or if they're due for getting their blood pressure checked, or their diabetes labs checked. If the blood pressure is high at both checks, they check it twice and it's still elevated, the medical assistant in subspecialty care can automatically book a follow-up appointment at one of our blood pressure screening stations. So I know that that's tough for systems that aren't quite so integrated. Maybe, thinking about seeing how you could incorporate some of your higher volume clinics that may do more blood pressures. For example, Women's Health, the Women's Health Clinic might be a good place to start, integrating that kind of service with them. So the other piece that's critical to our success is outreach. So when a patient gets a blood pressure that's elevated and they don't follow up, what happens? So we have a back office database where we can pull up our list of blood pressure patients, our hypertension patients, same time. We can sort it by the higher risk populations. We can sort it by ethnicity, age, comorbidities, and the medical assistants are expected to pull those lists on a regular basis, review it with their physicians, and to book those blood pressure follow-up appointments. Another great methodology we've been using is to encourage checking the blood pressure when we refill all medications, because we can see it in our Epic system. I don't know how other systems have done it, but we can see the blood pressures with every refill. We can review blood pressures at every opportunity. And finally, when the phase pharmacists are refilling medications, they also are expected to review blood pressure and make sure they're in control. So if we have a patient who has diabetes, the pharmacist is refilling their insulin, they are also expected to check and make sure their blood pressure is being taken care of correctly. So just to summarize what our strategies for success and what our challenges are. First of all, we definitely foster a culture of excellence where everyone participates and everyone benefits. And we've worked to integrate those services across facilities and departments, and really making it very easy and very foolproof for patients to get their blood pressure rechecked. And we've also worked on defining the why. So we promote hypertension importance at every opportunity. We've leveraged cardiology to educate physicians and staff. We also have a small group of primary care physicians that act as our cardiovascular consultants that do lunchtime talks for our physicians. They act as content experts for the phase pharmacists and the department at large for their local facilities, and help coach and counsel physicians who might be struggling or underperforming. And we try, like I said, we also try to provide care in the moment and make sure that when we see a patient and their blood pressure is elevated, that we have a plan to address it and follow it up. And finally, we have reports that are timely and actionable. So when we pull up a report, it's reflective of the current blood pressure control of every patient that we're looking at. It's not a week or 2 weeks old. It's actually same time. So finally, challenges. We definitely have our challenges, and probably the biggest challenge is just the geographic size and the population size. And when we talk about a group that's this large, it's hard to move everybody in the right direction. Like I said, we have almost 300 doctors in our department. So getting everybody to have the same passion, energy, and standard work around blood pressure control is very, very challenging. And getting the message out, even just getting the message out about workflow changes can be very challenging. We've also had a lot of growth since 2014. We've had a tremendous growth in our physicians and patients. I think we have over 100, well, with a turnover, we've probably had over 100 new primary care doctors in the last 2 or 3 years. Huge number of new patients also. And finally, there's a lot of new technology out there, and how are we going to integrate that into our systems? The home blood pressure monitors, for example, we know are can be very accurate and very helpful in controlling blood pressures, but how do we integrate that into our Health Connect system so they're accurate and actionable? All right.
Excellent. Okay. Questions?
Yes.
This is California Chronic Care Coalition. How are your medical systems trained, and how do you know that they are doing blood pressures right and recording them correctly?
So good question. We have a standard work where we have the managers make sure that they follow them, they audit them. The managers go around and they say, well, you know, are you having your patients sit with their feet flat on the floor, their arm elevated to the right level? Are you checking it a second time? So we actually have unit managers that go around and nurse managers that make sure that the work is getting done, that they've been trained correctly. We also have in-services a couple times, I think at least once a year, where the medical assistants review the appropriate workflow, and they're asked to demonstrate what they do when they check a blood pressure.
Kristen, a question.
Sure.
This is really great. Just wondering, you know, when we were getting trained a long time back, we were told the manual blood pressures, like the manometers, were the true gold standard. So I was wondering, what was the end, the denominator for your study?
Oh, the automated BPs? So I don't know, those are outside studies. I don't know the end of those.
And are you connected, are you interfacing with the home BP monitoring for the members with
We haven't, no, we haven't, we haven't figured out how, we haven't integrated either home blood pressure or home glucometer readings into our Health Connect system. That's a gap that that we're working on currently. And we know that, you know, those are critical pieces moving forward, that when people check their blood pressure and their blood sugars at home, we should be able to automatically link that up. We shouldn't have to call people and write them down manually.
We're waiting for Kaiser to figure it out.
Hopefully
So hurry up. Here you go.
I have a follow-up question.
Sure.
Is it's not working?
The speaker.
Great question, or great presentation. And the follow-up question, her question about the automated blood pressures, is since most of our outcomes data comes from the traditional the traditional measurements, we do have some outcomes data with the ambulatory measurements. Do you follow those folks that pass the automated readings to ensure over time that they don't become at risk again?
That's a great question. You know, I don't think we have a protocol. I can tell you that I think a lot of the people that we use that on are people that the physician sees frequently and thinks that probably there's an anxiety component to their blood pressure. And we often don't necessarily recommend it with every patient. But when the patient says, my blood pressure is always 120/70 at home, I come in here, I get nervous, I get anxious. We recommend really reserving that mostly for people who you think that there's a white coat hypertension component to it. And those tend to be patients we see fairly frequently, but like I said, we don't do it on every patient with an elevated blood pressure. If we think that's an accurate blood pressure and the patient has a history of high blood pressures, we tend to just treat it.
Thank you.
All right. Thank you.
I have a question, if you can hear me.
Yes.
We can hear you.
I thought we'd hear from y'all.
Okay, so I think this has been great, and clearly Kaiser has the success story that we all look forward to for all of our programs. I was curious that I think it's a great idea for the phase pharmacist to review blood pressure at every medication refill, because there's a lot, that's a great follow-up program. That means every medication refill that we as clinicians are fighting, we keep nudging after that, gets a review of their blood pressure. Has Kaiser looked at how additional cost is handled or how much it would cost? Obviously, a pharmacist is going to be involved with a medication refill no matter what. How much extra time does it take for them to not look at pressure? What cost of that for Kaiser?
So I'm not sure I can answer that off.
Or not?
I'm not sure I can answer that off the top. There is an additional cost. We haven't really, I don't think we've assessed how much more time, much more time or effort or cost it's going to take for this patient population. Well, thank you. Oh, yes.
So I noticed that your treatment plan was mostly medication. Is there diet, nutrition, all
yes,
that?
Absolutely. So we also have, We also have classes for hypertension. We have great online programs to teach people about the DASH diet. That's a good question. We have an easy, we'll call it our quality button, so we can automatically populate an after-visit summary with information about diet, videos about diet and exercise to help control blood pressure. So it's pretty easy for the primary care doctor to give patients instructions, on other things you can do. But you're absolutely right, lifestyle's an incredibly important part of this.
All right.
Thank you.
Thank you, Dr. Robinson. That's excellent. Well, Kaiser has really shown tremendous leadership and the processes that they've brought success to them are things that I think are something I take home. And I heard a lecture last year from I guess a colleague of Dr. Robinson and made some changes in our own clinic that I think make a big difference. Now we're going to go next, actually, I think to Jean, Dr. Shahdadpuri, or Dr. Flinn. You're looking ready almost.
We were slightly yellow.
You offered to go last, Scott, when we split it around over lunch. So,
Okay, so now it is our pleasure to hear from somebody who is showing in her work and the colleagues and those that she's worked with, they have found some great success and really moving forward. And so we want to compliment them. HealthNet, Jean Shahdadpuri is the Vice President and Senior Medical Director at HealthNet, and covering the medical groups in Los Angeles. So she flew up today with her father from LA. And we're so glad that she's here, has a wealth of quality experience, was a CMO with Tenet Health Systems, and just that how we can coordinate care and bring some great quality to our different practices. We're sure appreciative that we can learn from her. Has an MBA and just so many things you can read about. She's also a scuba diver, so that's great. So I'll turn the time over to you, Doctor.
And we'll have to get her to bring her sitar sometime and play for us at one of our RightCare gatherings.
Very, very good observation, Hattie. So thank you, everyone. It's such a pleasure to be back every year here. I wish I could come here more often. It just is amazing with the whole green, and this location specifically is really nice by the way. So thank you, Hattie, for welcoming me and my father. I'm sorry I was supposed to be on PTO. He's visiting from Dubai for his anniversary, and I said, Dad, I can't get out of this, so would you mind just coming with me? After all, you have a first-hand experience with cardiovascular health. So thank you, and my heart goes out to everyone involved with the fire, so please stay safe. It's the second time, and I think you're just putting up with a lot of grief and distress. And so I'm going to start my presentation.
There you go.
Okay. Got it, Brian, I got it. I should have gotten this better. Okay. So let me start with some facts about our organization. So HealthNet was acquired by Centene Corporation a few years ago, and we are now the largest Medicaid health plan in the entire nation. We're also present in 31 states, 2 international markets. It's Puerto Rico, and one more market that I can think of. There are about 14.4 million members now. It's the fastest growing company, so it's number 61 in Fortune 100 and 49 in the fastest growing companies. It has about 45,000 employees. So Centene had a footprint in California with California Health and Wellness, which is up in this region. And HealthNet was essentially in Oregon, Arizona, and LA. So Centene also acquired a brand new plan called Fidelis in New York, adding about 1.6 million members, out of which 65,000 are Medicare and the rest are all Medicaid.
So that puts us in a good position with the spread geographically and exposure to all lines of business.
Can you get a little closer to the mic, please? So when you turn that way, you're farther from the mic, so just
Thanks.
be aware.
That's awesome. Thank you, Annie. I'll try to stay still. Just a brief overview on our membership. We have about 2 million Medi-Cal or Medicaid members, 14,000 dual eligibles, 150,000 Medicare, and about 850,000 commercial. We're in all lines of business with commercial, with the PPO, ECPPO, and exchange. And then we have our capitated medical groups, I'm sure all of you are aware here. And then we have our fee-for-service providers. So we get the data from claims from the fee-for-service providers and through encounters with our delegated medical groups. And that's how we capture all the data. This is an integrated approach that we follow with our organization. It's member in the center. And then we have the care coordination, benefit management, person-centric programs, and all the IT programs which are around the member. And then we have a broader peripheral services which revolve around life, health, and wellness, the pharmacy benefits, the specialty pharmacy benefits, the dental vision, telehealth, where we're making some great strides forward, especially in some of the Central Valley and Sacramento areas. We have in-home services. We have care management, behavioral health, and behavioral health is another really important field where we're making some good headways with integration. So our reporting that generally used to have chronic condition prevalence reports now has a mental health overlay that's going to tell us what are the mental health conditions overlying the medical, physical health conditions. And we could actually see which one of those is the driver for that condition. So if you're depressed and you're not taking diabetic medication, you go for the depression first and then the diabetes. So that's a new addition. We're still working on the reports from the Centene system, and that's going to be very refreshing later this year. So this is what our initiative was based off, James Duddle's study. And we met him in UC Berkeley last time, which was really good. But he did an all-phase study, and probably a lot of you are aware of, where there were about 170,000 individuals with diabetes or cardiovascular disease, and they were put on a cardioprotective bundle, and were found to have lower risk of heart attacks and heart attack hospitalizations. Now, the initiative is not mirroring this exactly, so it was a combination of this that inspired the idea, and then I combined it with the Be There San Diego, which is very successful with their coaches. So it's a combination of this with our coaches, which I'm just gonna come to next. So introduction to our cardioprotective bundle. It was meant to be a pilot, but we didn't really go with the pilot mindset, and we went with the entire membership of HealthNet and California Health and Wellness, so the entire California. And let me go to the model. So our model was targeting California as a region, and we got all lines of business, and it's really nice to have any initiative spread across all lines of business, because when you go to implement it at a member level or a provider office level, you're not telling them to read the label off the member's card saying, are you a commercial or Medicare or Medicaid? You're just treating the condition as a condition and dealing with every single member that walks into the office. So this was for all diabetic members, and there were about 183,000 of them over the age of 55, both with hypertension and or cardiovascular disease. And the long-term goal was to prevent cardiovascular events in this highest risk population, and to educate these members on their conditions, and to achieve, of course, the quadruple aim now. This is some of the stats that Kristen, I think, also presented. We all know anybody with diabetes has a higher risk of heart attacks and cardiovascular events, but if it's a diabetic with hypertension, that puts them at the highest risk. So 183,000, when we started pulling this data about a year and a half ago, we found out at that time, 27% of our population was on the bundle, and 63% was not. And now, when we combine the California Health and Wellness population with this, we have 40% of this membership that's not on the cardioprotective bundle. So 40% of these highest risk membership are not on any medication. They're not ACE or statin or aspirin. And of course, so they're walking around, running a real high risk of getting a heart attack or a stroke. So that was a pretty shocking statistics for internally and externally when I presented it to my provider groups and other forums, and kind of sprung our internal team into action. When I first pitched it to my committee, our senior executive leadership committee, I said, I don't want to start this unless I know, are we an insurance company or are we a healthcare company? Because if you're really a healthcare company, it just behooves me to know that 40% of our membership are not even on aspirin, ACE, and statin, which costs less than $5 a bundle. So I think that got some attention, hopefully. And so we did get a Target BP award this year, which earns a national recognition for the commitment to improve high blood pressure and reducing the number of Americans who have heart attacks and strokes every year. So this was a good milestone. So this is the geographical diabetic population overview, and shows us the density of the diabetics in the entire state of California. So not maybe surprising, highest concentration of diabetics was in LA, San Diego, and Fresno, fewer in Bay Area and Sacramento area. California Health and Wellness, the higher concentration was more from Imperial County and I think Boot County.
Which county where the fire is?
Where the fire is.
Yeah.
So now it's in the triple, quadruple valley there. So that's our target population, already mentioned. Now, even though it says cardioprotective bundle with the dosages there, the way our initiative is rolling out with the provider groups and the providers, it is not prescriptive of the dosage that's mentioned there. So we said, let's just open the doors and let's just have the physicians take a call and please put these members on a basic cardioprotective bundle. So aspirin, statin, and ACE/ARB, and they can choose based on how they know the patient and the side effects and how they react to it. They could put them on any of these in any one from each category and any dosage. We also didn't want to get into a lot of back and forth of why this statin or why this much dose, so we just wanted to start. Now, the secret sauce is the healthcare coaches. And these healthcare coaches are diabetic educators, nutritionists, counselors, pharmacists, and wellness coaches. And they're trained in motivational interviewing skills and are very effective in engaging with the members. They go at the pace the member's comfortable. They push to engage if they want to be engaged, and they go and they have more time than the physician or the provider in the office. So this is kind of my honeycomb way of describing the support system that I have for my initiative. So the biggest box is I put data analytics support. So extremely important to know what is your N, how many are on the bundle, where are they located, who are their PCPs, are they engaged with any other programs in our company, so disease management, case management, IVR calls. The purpose of doing this was to make sure it's one effective touch, and I think that's caught on now. And our entire organization, where we know multiple people touch the members, we're telling them to have one effective touch. One touch, whoever that is, wherever that is, to address all their issues, whether it be care gap, or explaining the disease conditions, or checking on med adherence, or checking on care gap, screening, preventive. It just has to be all in a flow. The person who has the best rapport with the member addresses all these measures with them. So we do have data analytics support that shows all this data, also gives us the pharmacy data of the fills and if they were on the medication but dropped off, so we know they started on it but now dropped off. And we also have their baseline utilization trends and their baseline cardiovascular events. So we're actually, in terms of the control group, we're not segregating or preventing anyone from getting on the cardioprotective bundle, but we're taking the members that we haven't been able to reach or historic members that are not on the bundle and seeing how many heart attacks they had and then compare it to the ones that now are on the bundle to see what the comparison in the heart attack rates are there.
Do you have that data yet?
It's because these members have just started being on the bundle and are not long enough on the bundle. When I first compared historic data of just not on the bundle versus on the bundle, it was 1/3 the utilization cost, but the end was so small that I wanted to make sure this is an ongoing thing that we measure. And then we have My Strength program, which I'm really proud of. And the team members are here from HealthNet who actually have a big role in doing this. So this is a patient self-paced portal online engagement tool. Doesn't involve any physician or provider or RN or coach, but it kind of runs the patient through their condition. How much do you know of the condition? Kind of find out what the motivation factors are, and then kind of go along to see now are they ready to actually engage with a coach or a provider. So really good rates of participation and outcomes that I saw last time. Then I have my additional support with my clinical program managers and the regional medical directors. So the regional medical directors with their clinical program managers have a list of all the members and which PCPs they're with and which medical groups they're with. So when they are engaging with the group, the idea is to select or appoint a clinical champion, and some of the groups we've made exceptions and have non-clinical champions. Anybody who's very passionate about this, not the ones who are always in that work group doing it all, but somebody who has the time to go with these lists to each provider and show them what their rates are. So Dr. X, do you know half of your population's not on the cardioprotective bundle? These are running a risk of falling and have a heart attack somewhere. What can I do to help for you to get on the bundle? It's been extremely effective just because we do not have those periodic and intense touches with the providers, and these clinical and non-clinical champions have done wonderful. So they now report up and give their updates of compliance rates, and we're trying to develop a kind of a peer-to-peer reporting to show one better than the other. You know, we always know that works best, to see what's the progress they're making. And I have docs who are calling me like Friday and Saturday saying, I got 2 more. I got 2 more docs. I got 10 more patients. And I'm like, way to God, I'm taking these calls because it's lovely. So the momentum is kind of catching it. It's really nice. And I did tell them I'll put their name on the Hall of Fame somewhere in these slide decks. So they're thinking that I'm going to put a list out, and I might do that. So we have an online Omada DPP vendor that is a vendor that engages with the members online. It's more peer-to-peer support on weight loss and wellness. Not so much on hemoglobin A1C control, but it's more health and wellness and diet and exercise. We have med adherence programs from our pharmacy department, and they range all the way from IVR calls to pharmacist calls to now we have something called electronic pill boxes. They're pre-packaged pill boxes that the member picks up, and if the member forgets to take the medication, an alert goes to the phone, and they know whether they've taken the medication or not. And you know, the way I am, the downfall is that it could be any vitamin pill that they forgot, but the pharmacy puts those medications in that electronic pill box. So that's working well. The results are pretty encouraging, although the N is really small. And then, of course, we have the provider communication with our member communication with our health ed that does an amazing job with educating the members. So this is what catches traction for any health plan or a clinical team or a medical group that's trying to do this initiative, because this initiative involves case management, medical directors, pharmacy, QI team, health ed team, culture linguistics team, and Martha, I'm probably missing out somebody, and of course the data analytics support. And it's really difficult because they're cross-functional in a matrix organization to get everybody to be as pumped up as you are and to work with you. So this works really well because you go out saying it's going to impact 6 HEDIS measures, and you have quality team on board with everything. And these are genuinely the 6 HEDIS measures that our coaches touch on. So when they're talking, they're checking on the beta blocker, the statin therapy for diabetes, statin for cardiovascular disease, the CBP measure and the NPM measure. And for the medical groups, this works as well. And we have seen a difference with these HEDIS measures because they're going after targeted members and targeted PCPs. So we have seen an improvement in these measures, and it's all lines of business, so that helps. So results. These were our results till date. We did find that the utilization rates for all these cardiovascular events decreased. Our patient engagement, so we have a patient engagement score, and there's an algorithm behind that. Now the patient engagement score, if it's 20 for this cohort of 100, that became more like 50, 57 when we started having coaches and pharmacists and diabetic nutritionists and counselors call them. So there is something about who the member relates to and would like to engage with and have those conversations with. Now the PMPM cost decrease, we did already, it's not even been a year, and we did save millions of dollars. We did, I'm not allowed to say how much, but we did save millions of dollars, but I was allowed to give the percentages. And let me tell you what these percentages are. So for Medicare, Medi-Cal, commercial line of business, all of them reduced, and we did the entire statistical analysis. We have a special team that sees if there's a regression to mean or any other probability chance happening. So this went through all the testing. But this utilization was not around everything in the member's life. So this wasn't asthma, this wasn't motor vehicle accidents, this was just cardiovascular events. So any utilization that was around cardiovascular events was reduced by those. And we saw tangible dollar savings. So this year I was so excited to present this to my executive leadership committee to get more funding and more resources to do better. And they gave me a target that was almost double. But they did give me the resources, so now I'm up against a bigger target. But I do have some good traction on the resourcing and the funding that goes with it, so I'm really happy about that. These are some of the quality improvement activities. I'm going to go a little faster on these. Much of these activities are most of the activities that the health plans do. So reminders by email, IVRs, text messaging, incentives, in-home visits.
Can you tell us more about the incentives? That's really important.
Definitely. You know, I actually have a better slide. Can I jump a little here? So this was interesting. We all have incentives. We have incentives everywhere. We have incentives for members. So they get gift cards if they come in and close their care gaps. And it could be one for that member, but once they come in, they get their entire care gaps closed. We have at the provider level money, which is $50 per care gap closure. So per care gap that they close, they get 50. It's very easy. Get the mammogram, you get 50. Get the lab done with hemoglobin A1C, you get the 50. We have another one that suits more of a community clinic setting. So we have a whole bunch of incentives, and then we have it for the FQHCs who are designed a little differently. And so we do have and then we have delegated PPG incentives that's based off more on encounter submission and quality, so that all the data that's coming in from the providers, the MSO does a good job of submitting it to us. I mean, the management company. So this was interesting because there was actually a member incentive research study, see what works. And they split the cohort, and they said, all right, if we give it to you at the point of care or we split it into two where you get a little bit at the point of care and one when you actually get the service done to see what worked. The third and the fourth option actually has to have a provider opt-in. Now these results are not yet out, but there's a sweet spot for an incentive for a member. And that's what we're trying to get at. Is it 10? Is it 15? Is it 25? Is it that coach called? What is it that makes the member go in? So results are going to be next year, so that you can call me next year too. So these are some of the performance slides. Now these are a little difficult, but these were canned reports. But all I wanted to say was the blues, and the darker the blues goes, actually that's better. The darker the blue, the better we're doing. Orange is bad. So orange bad, dark blue good. So that's easier. Now the 3 bars are the 3 years. So 2016, 2017, 2018 are the 3 bars. On top are the counties, and on the left side are all the metrics. And so this is all the CDC measures, and on top are all the counties. So blue's good, orange is not so good, and you can see there are a few oranges.
We would love your help here in Sacramento understanding why it's all orange and
All
yellow
orange.
here, and let's work on some targeted programs
Yes.
for this high heart attack and stroke region. This is the worst heart attack and stroke region of any metropolitan area in the state. So we'd really love your help.
True. And we did have a whole Region 3 focus group that we called in all the stakeholders, and it would, well, Sacramento is called Region 3, sorry Frank, I was looking at you because you started this. But we did get a real good analysis on what's happening with this area. There were several things, but I think the one thing that really stood out that we're working on now is community engagement with the members, not the doctors. Doctors are too far apart, can't get to them. In their busy lives, they're not able to get to the provider's office. So we're looking at ways to entrench these services in the communities. And so a lot more CBO activities, involvement will be coming up next year from Health Net.
So something we can talk about a little bit later is the potential of putting up public airways messaging to get straight to the patients through billboards, radio, television. Because this public right here is really in trouble.
True. We do find they're very heavily engaged in the community, and so that's where we're trying to get at, through promodoras, through community health workers, and things like that. This is another set of metrics. So we have CBP, and SPD, which is basically the statin therapies, statin adherence. Again, Sacramento is the first column, 1 blue, 1 orange, 2 yellows. So 2 yellows are above, or well, above the 25th percentile, which is called the minimum performance level. Would definitely like to see all of this blue. You have, so these are more measures on the left. Again, Sacramento is the first column for Medi-Cal again. This is California Health and Wellness, and they're separate slides. Sorry about that because the databases are still separate. They haven't merged completely. So this is what CHW defines as Region 1, Region 2, Region 3, and their CDC metrics. Again, more metrics. Now, the activities that we're doing for this population, we of course have visibility for the groups to see all their member level care gaps, and the report cards that's taken by our team in their joint operation meetings, and they strategize on how to get them above the performance level. We have in-home visit programs, we have provider training education on gap reports, and we also have in-home visit program by a team called Member Connections now, which is amazing. They go to the member's home in a very non-intimidating setting and just see what is in their home. You know, how are their medication cabinets looking like? Do they understand all the mailers? So this one person showed a stack of mailers that were coming from all different kinds of healthcare, and they were all in English, and the member, you know, couldn't understand English. So I think what you can find in an in-home setting is expensive to do, but it's valuable. It's valuable. So these are, these are uses of retinal cameras in telehealth, so to capture DREs, which are diabetic retinopathy exams. We actually pay for the cost of the cameras. The ideal place to place these is in the FQHCs. You have greater critical mass of members there. And then University of California, Berkeley's department, they do their eye exams and they're really, really good. They provide this service. Go, Susan. They actually provide this service and provide the readings, very good quality pictures and good readings and accurate readings. And their hit rate I have seen is in the high 90s. So really, really good. A little expensive to put the cameras. You can't put it in a doctor's office because you don't have the critical mass there, but works. This is diabetic outreach, again with some incentives. So this gives the detail of what gift cards and how many we gave and how much was the engagement rate with these gift cards. So we give a gift card where we see are they using these gift cards to buy, and so shows kind of the engagement of the member. Some more flyers. We do fax blasts. I mean, these are great, but we sometimes don't find them being as effective as we would hope. This was good because this kind of did a driver analysis of what is getting them to not be medication adherent. And there's a lot of information there, but basically we listed down all the root cause analysis that we found, and the change ideas are the ones that we implemented. So we figured these people are going to the lab, but we're not getting the lab values, or we gave the list to the lab to call them to make direct appointments. CVS health tags, so now all diabetics, irrespective of what medication they're going to CVS for, get a little blurb about cardioprotective bundle, and do you know about aspirin, statin, and I think we wrote it as hypertension medicine. Please go ask your doctor. It's a little blurb, just enough for them to read when they're in the line, you know, for the cashier, to say, oh, maybe I should be on this. So small thing, but I think whoever is reading the stuff that they have in their hand might work. Medicare, so these are again Medicare performance graphs. And we have Medicare HMO and Medicare, and then we have the same, so Medicare, I think we made probably the most improvement in, because dark blue is 75th and above for all our CDC measures. I don't know why. I think what I hear is Medi-Cal population is a little difficult to get at, to find the right numbers, and then to engage them and to actually get them to change their habits and behavior. But Medicare, we have good results. Even for these measures, there's no oranges. And then these are some other measures. And so some of the activities we're doing here is similar. So when we go meet a delegated group, we take all lines of business report cards and care gaps. So for a Dr. X, we know exactly what are their care gaps, and where they're lacking and how many they've closed from last month to this month. We have some annual pocket wellness calendars to Medicare members, IVR calls again, text messages. I think we're collecting now a big database of email addresses. So I'm hoping that's probably the way they want to engage it, and the brokers are now asking them, what is your preferred method of engaging? So, you know, sometimes they give an address that changes or they move out, but if their preferred method is an email, and we have email, we never lose touch with that patient. So that's great. And we actually didn't have a field to catch your email address, which we're building now. So that's great. Living well with diabetes, I have a picture of the infographic, I think, later on. This is interesting. Again, another online tool. Take charge of your health. Again, something that the member goes through at its own pace to understand their own condition, available for Medicare and commercial members only. And those are some screenshots of the website. These are the IVR calls in the diabetic mailer that we send. Again, mailer. Okay, so this is the example of the flyer that we send out. Commercial and marketplace. Again, we have performance slides. So we have commercial PPO, EPO, HMO, and the the shop. But we have all the metrics on the left. You still see some oranges, so more blues on top, more oranges in the bottom, so which means like we have less of hemoglobin A1C testing, but when they do get tested, we're pretty okay with the control. These are some more metrics. And then again, some of the activities that we're doing. So for ease of seeing this content-heavy slide, I just put the news. These are the new things we did in 18. So we started the ADA member, so American Diabetes Association member, bi-monthly magazine subscription mailing that gives a lot of information for the diabetics and the pre-diabetics. We also sent care alerts, which was new, through the system to specifically the RightCare Initiative members to tell them that they're not on any ACE or ARB. These are the ones that dropped, that were on the medication but dropped off, and that care alert goes and says, why aren't you on them? And they're given a number to then call back and say, did you not get to the pharmacy? Did you forget? And I'm trying to capture the reasons why they're not compliant. It's not very consistent, but there are things like the brand name looks different, the box looks different. It was blue, it's green now. There are things that people associate the pill with, and they don't necessarily see the name, and it might be a blue box or a green box. So it's a lot of good things that are coming up, but the reasons for med adherence could be so many. And of course, the award that I talked about. We have some IVR calls here as well, and I think we reached out to 18,626 commercial members. This was interesting. We measured, this was an intervention that was done on medication adherence where we actually did some outbound calls and provided faxes and member letters, and then measured what was the outcomes there. And these are the exchange activities. This is a clear communication project, which was a CNL project, so more language-based, and we had put English and Spanish, ask me about your disease. So it's asked me about my disease, cultural sensitivity, teach back, and there were brochures and posters and that were given to more culturally specific population. And that's all I have. Questions?
I have a question.
Hi from New York.
Actually, it's Washington, D.C., but we'll go with it. Because the live from New York sounded better. So. One question about the American Native was your with $10 per member, please the specific task, putting actually the incentive on them as well as the provider to do it. But I was a little disappointed with the 3.5. Even for the incentives, a very few number of individuals actually take you up on that. What do you think was the difficulty in interesting people in that incentive program? Is it that it was at Target, you should have the Amazon, to make it more of an incentive, or is it that people at that point don't hear about it, or they just are unwilling, even with an incentive, to show up for those diabetes and blood pressure checks?
I did get most of your question. I don't know, I'm getting a lot of groups. I think his question was, why isn't there a high uptake for your member incentives, both for the members and the provider? I think that was the question. The devil is in the details. It's very geographically different, very provider specific, very PPG specific. So I'll give you an example. One of my medical groups was almost 100% Korean. We were giving them gift cards for, I think, Walmart, and there was no Walmart there. So we actually spoke to our team and we said, can we give the gift cards, which is the Korea Mart, which was right there. And so what we did along with that, but then it gave me the sense that members are probably visiting this place more often than I thought. So we actually had 2 people camp out there, like the Boy Scouts desk, and give out flyers in Korean, and they were Korean-speaking people. They had an amazing engagement rate and output from there. So they gave the flyers. They got questions on, we are having trouble with HealthNet with da-da-da, and so they could troubleshoot or at least direct them to the right place. And that grocery card or Korea Mart card. So this was the most interesting thing though. There were a list of 10 or 20 members that this medical group could never get hold of. And these 2 provider reps who were there at the desk were, along with a medical assistant, a provider office. So this medical assistant goes, that's the sister of the member, catch her there. That's the daughter. And so they caught these relatives and said, why aren't you getting your mother to our provider office? Oh, okay, I'll bring her. It was, that kind of, tracking and tracing the members is pretty unusual. So something that really is relatable to the member is important. I think also we don't do a good enough job making everybody aware that there are incentives that exist. I mean, these mailers, guys, how many of you opened 100% of your envelopes at home? I mean, they're just mailers. They're not necessarily getting their attention, so they just don't know about that. So I think it's ideal if a PCP reaches out to the member and says, there's a member incentive. So that's the kind of approach we're following.
Thank you.
Can I just add a couple things? I think Sacramento has kind of been a pilot for a lot of the programs that Dr. Shahdadpuri is showcasing today. And I just wanted to emphasize that the one-stop clinics that we've operationalized with some of our high-volume FQHCs such as WellSpace and Ellicott, we are getting a good response from our members. But for us to get 75 members, say, that have 2 measures that need to be done, about 500 calls need to happen. So there's a lot of outreach involved on the ground in personalizing with the member to get them into the clinic. But it did start in Sacramento under Dr. Akbar's direction and Dr. Shahdadpuri's, and now it is a statewide initiative. We're making it more accessible for the member based on their CNAL, cultural linguistic requirements, or their transportation, or having all of the services in one stop at the clinic. They go in, they get their services that they need, and they walk away with a gift card. And so, for example, we're doing 2 with WellSpace in December on the 1st and the 15th. And members will walk away with $100 of gift cards at Christmas time just for taking care of their health. And it's really unique to HealthNet. So I just wanted to share that success, and it started in this region, focused on diabetes and heart health and some of our other women's health measures.
Awesome. Thank you, Martha.
One quick comment and then one question. Comment, in Kern County, there's doctor groups, 25 to 40% of the patients in Medi-Cal were unreachable because they didn't give accurate phone numbers. That's a chronic problem we're all experiencing. Question, on the medication bubble, how are you capturing, and how did you capture in the past whether somebody was on aspirin or not?
You asked me that question and you worked with us. So aspirin is an interesting one. Aspirin cannot be captured, but we do have claims for aspirin. So there, for Medi-Cal, and I think for some other products, there is a coverage for aspirin. So we do have claims on aspirin, but the majority of it is something that the coach or the pharmacist call is capturing, saying, are you on aspirin? So you remember all the calls that the HEDIS team used to make for those? Now they're capturing aspirin as part of their script. So it's been inserted in the case management script, the HEDIS team script, and so they're capturing that information verbally and then putting it in the system.
Thank
Your
you.
baseline measurement, the 40% that weren't on, I'll let you run on. The 40%, was that just statin, not being on a statin and ASR, or did that include aspirin?
It did include aspirin. Now, no, so I didn't assume that the ones that were not showing the aspirin are not on aspirin, so I had to combine it because I didn't know. So it's the combined bucket of showing that they're not on anything.
Thank you so much. Okay, now we have Dr. Scott Flinn. Not only from LA do we have a speaker, but from San Diego, and Dr. Flinn, Regional Medical Director at Blue Shield of California. So grateful to have him. Another military guy. We've got a couple of us Air Force, and then we've got Navy. That we appreciate you. Dr. Flinn worked with the Navy SEALs and had a couple of tours. Much more active, I think, than I was getting into the action. But we're glad that he is here and share with us from Blue Shield. Thank you.
Thank you, Matt. Afternoon, everybody. How we all doing? I'm the one standing between you and freedom. So you've been sitting for an hour and a half now. So why doesn't everyone just kind of stand up, stretch your legs as we start going through this? As they say, the brain can only absorb what the seat can endure, right? Alrighty. And there it is. All right.
Can people hear Scott in the back? Can you hear him, John?
Pretty good.
Yeah, a little louder, Scott, if you could.
There's the song right there, right? A little bit louder now? Very good. All right, so I'm going to give you an update on where Blue Shield is in our RightCare initiative efforts. To date, I have no financial relationships to disclose. Burning objectives are up there, obligatory. Alrighty, so we started this effort in 2015 when we were mandated by DMHC because of our acquisition of Care First to participate in the RightCare initiative. And we also developed a plan to reach the 90th percentile for the RightCare initiative goals by the end of this year. So this is from October 2015 to the 90th percentile end of this year. So our good friends at Kaiser, how long have you been working on this? 25 years maybe? Yeah, how long did it take you to get to the 90th percentile?
Long time.
A long time, about 15 years or so, right? So we're supposed to do it in about 2.5. So we're giving our best effort, but it's really a task, right? We are participating in the UBPs in San Diego and here in Sacramento and also in LA. And also this year, actually this 2 weeks from now, we're going to be starting one in the Bay Area too. And I'll detail a little bit of that as we go forward. Our strategy was that we actually looked at this and as an organization decided that hypertension, diabetes, and actually readmission reduction are our top 3 strategic goals for quality. So that's a pretty powerful statement for a company of our size to be able to say this is what we're going to go after when there is so much, as we all know, out there to do. Just for background, we have about 4.1 million members in all lines of business in California. So about 25% bigger than what HealthNet has here in California, but similar distribution in terms of all lines of business. We do have internal corporate incentives that are tied to those goals, so our leadership and all of our staff do have money that's at risk personally, so that helps to align incentives internally to get everyone focused in the right direction. And we do have quality incentives for provider organization, our participation in IHAP for P, as you all know, and through our ACO program also, we have quality incentives that are in that. We have approximately 40 ACOs now statewide, and we have quality incentives tied in through that way too. So we do have some money tied into this. As you know, money is a motivator, but as alluded to earlier, what's the most important motivator for providers? Peer competition, right? So
Yes.
We'll show what we do, how we try to get that involved in here also.
How do you do that?
Well, we'll talk about that shortly. Yes, thank you for that. We did, so when we looked at the state of what was going on about 1.5 years ago, we saw there's a UBP here in Sacramento, one in LA, and one in San Diego. What's the large population center that didn't have one of these to try to help spread these best practices? And that would be in the Bay Area. And where is Blue Shield California headquartered? San Francisco, right? So we kind of looked around and said, well, this is kind of silly. We're doing all this work around the state, but not in our own backyard. So we partnered with Hattie and some folks at some of her friends that she has, including Stanford, to start the UBP chapter in the Bay Area coming up in 2 weeks. And so congratulations to Hattie for that, pulling that together in a very short time. Well done. It's a monumental effort. So thank you very much for that.
Should I thank the Navy SEALs?
No, nothing to do with that.
That's how I feel, because they trained him and he was
We were
able to
never
pull
here.
it through.
Yeah.
So we forgot to mention in Scott's introduction that he was our co-chair in San Diego, and in this very understated way, speak softly and carry a big stick. He was able to really motivate through that peer pressure in San Diego to achieve a very substantial reduction in heart attacks, and for that, and all your other service, I want to thank you.
Thank you. Right, so the interesting thing for us, of course, is we're a health plan, as Gene alluded to earlier, right? We're a health plan, we don't have providers. Kaiser does have that advantage, which they leverage very well, and we really appreciate learning the lessons from our partners in this effort at Kaiser and with HealthNet about how to do this and how to do it well. So there is no, what's the best form of flattery? Copying, right? Plagiarism, and you'll see a lot of the stuff that we're trying to emulate from Kaiser, and it's an interesting thing to do that when you have to influence the provider organizations. Not that Kaiser doesn't have to influence also, but it's a little bit easier when it's all one organization. So we're trying to do this across the diaspora, as we say. So we developed a 3-part plan to engage the providers and a tool to do the self-assessment with those providers, and then a means to track the progress of what they're doing. And that's really the key to this. So we engage the providers. I'll show you how we do that. And then we show them the self-assessment tool. And when they see the self-assessment tool and see what they're really doing and where their numbers really are, it opens a lot of eyes. And when they say that, again, that pure competition comes out, and they really start to think, how do we do better than that? We've engaged 26 provider organizations. Actually, this slide is now 2 weeks old. I had to send this in for CME credit. It's now 28 organizations, partner organizations that we've got employed statewide. When we started this, our first goal in 2016 was to get 2 provider organizations involved, because we wanted to work the kinks out before we scaled it, right? And for 2017, our goal was 7, and we got to 9, and our goal for this year was 20, and we're already at 26 and on our way to many more. So we're actually ahead of expectations for this, and it's a real testimony to the whole Blue Shield team getting out there and getting folks engaged in this. The presentation emphasizes 4 major points. Hypertension control can have a dramatic impact in a short time, as alluded to by the Kaiser presentation. Right? We always think as primary care docs, it takes forever for any kind of primary care intervention actually to make a difference. Well, with hypertension, that's not true. And we actually, with Kaiser's permission, borrowed their slides that show that you can have a meaningful impact in a very short time when you treat hypertension. Implementing some of these best practices are relatively easy and cost effective. When the groups look at the list of things, here's what you can do, they're like, oh, that's not that hard, we can do that. And that's kind of helpful that way, where they can get some quick, easy victories. There's published literature that suggests this actually works. We'll go over that in a little bit. And then you're probably not doing as well as you think you are. Because what doctor have you met that didn't think they're at the 90th percentile for everything? Right? And the answer is, well, maybe not so much. Yeah. So, and this is for you Rocky and Bullwinkle fans. This is kind of the hook slide we have is how to prevent 1 in 6 of your high-risk hypertensive patients from dying from a stroke or heart attack in 3 years. And again, this is the original data. I got this from Jim Duddle at Kaiser. This is where that number comes from. So if you put someone on the acethiazide and a atorvastatin 40 bundle, that is a 55-year-old or older person that has uncontrolled hypertension, you can drop the risk here 17%. There it is, a 2-year circle there. And that is a great number, and that's 1 in 6. And we all have seen those patients, you know, they're 55, 56, 57 years old, and you hear, oh, did you hear about Jim? Yeah, he had a heart attack and died the other day. 56 years old, right? I'm 56, really? That's pretty young, isn't it? Right? It's all relative. So that's what we're trying to impact. And when we talk to the doctors about that and say, this is your 56-year-old, you just saw somebody with this. In those groups and in those IPAs, they all know stories of people that this just happened to. So it's very meaningful that that gives them, you know, that hook. Why should I care? Because you know somebody just like this, and your intervention can make a difference. 1 in 6 in 2 years, you can change the outcome on. So what are those best practices we talk about? They include implementing a treatment algorithm. It's actually, the algorithm we have for hypertension is the one that was developed by Kaiser, which you just detailed, and was adopted by the San Diego University of Best Practices back in 2011, I believe, and incorporated throughout San Diego. It's also been adopted here and in LA, and hopefully also will be in San Francisco. But that, using a treatment algorithm, doctors sometimes really hate algorithms because we're taught as little baby doctors that you're always to be an independent thinker and you can't tell me what to do, I'm going to do the best thing for my patient. Well, you don't always know the best thing to do for your patient, and we're here to help you understand it and make it easy for you. Intensify that treatment rapidly. We do that through a number of methods. The biggest one that we recommend is actually having a pharmacist on the care team, someone like that who can help them titrate the medicines quickly. If you have a pharmacist and a pharmacy tech that can help you do that, then you can titrate that medicine every 2 weeks and get them under control relatively quickly. And the usual primary care practice, full disclosure, I'm a family practice doc, and I keep following patients like that. But having someone come in every 2 weeks to titrate their blood pressure medicine, I'm just not going to do that. And what usually happens in the primary care office, you come in, they see them, oh, I'll do diet and exercise, and 3 months goes by and they come back in and you see them and I'm like, okay, well, let's try something. And they put them on a small dose of hydrochlorothiazide. And then 6 months goes by and they come back and they get a little bit up on that. And eventually, a year's gone by, and you've burned a year and that patient still isn't under hypertension control. And then if you use these protocols and folks to help you with that care, you can get them under control in a couple of weeks or a couple of months. Much, much better care, especially if you're in that high-risk group, 1 in 6, right? Implementing a care team using a pharmacist and a CDE, continually measuring that success, and publicly reporting the outcomes. And I don't mean the outcomes that we just saw today for public reporting. That's at a very aggregate level. I mean a person-to-person level and that physician level. And that's why most medical directors only last 3 years. Right? So here's the algorithm, exactly what you described earlier. Start with that combo med, the ACE thiazide. And if that's not there, you add a calcium channel blocker. If that doesn't work, add a beta blocker or spironolactone. This has been here for, 10 years probably now, probably the same algorithm. When we present this to the groups, this is one San Diego adopted. The thing they tend to change is maybe what the calcium channel blocker is. They go, instead of amlodipine, they'll try something else. But in general, this algorithm goes pretty good and it's pretty simple. Right? So that's helpful. Down the bottom, you'll notice it says, if you have high risk, consider adding a statin. It's an additional 25% reduction in reduction of major adverse cardiovascular events. So the thing that gets you there quickest is hypertension control. The thing that tends to have the biggest bang for the buck is lipid control. So here's and this is why you do a combination med. You can see there, if you just have an ACE inhibitor, it's about a 10 millimeter reduction in blood pressure. If you add the thiazide, just adding a thiazide to that same medicine, look at that, 25 millimeter drop. That's why you start with the combo med. And you show the docs this slide, they go, oh, I can do that. That's not the size. Especially since the meds are generic now. There's no prior auths and that kind of thing to try to get those medicines prescribed. Having a pharmacist on the care team, this is one of the original studies that helped get the RightCare initiative launched when they looked at pharmacist-assisted titration of blood pressure control at UCLA. Much better outcomes than just routine primary care. Some of the things you can do to help the pharmacist to help you, you have a collaborative practice agreement. When we meet with the groups, we have a template collaborative practice agreement for them to use so they can actually institute it within their practices. The pharmacist can intensify the drug therapy per protocol, monitor related labs, address side effects, and they can work with the patient for the med adherence. And that's where the pharmacy techs, if they hire those also, can really come in, working under the direction of the pharmacist. Do that call every week or so to that member and see how it's coming, if there's any barriers to using the medicine, getting the prescriptions filled. And then they keep the PCP informed, and that's how the collaboration really works. They can also report on hypertension and diabetes medication prescriptions and how that med adherence works. The way we recommend the groups do that is they get a champion, as alluded to earlier. And we actually had this in my old group. This is how we actually did it. We had a internist who was one of the younger internists said, yeah, I'll try that. We had a nurse doing the Coumadin clinic, the anticoagulation clinic, and they were doing a great job. We brought a pharmacist in, and they actually just knocked it out of the park. We got numbers as good or better than Kaiser's for our anticoagulation population. And the doc saw that and said, that's great, you just stay over there in your anticoagulation clinic box and just play over there, don't bother us. But this intern says, yeah, I'll try that, let's see what happens. And his numbers were in the mid-50s, in hypertension control, which is, Kaiser alluded to earlier, right? That's where you started. That's where most groups are. They're in the mid-50s somewhere. And he brought his numbers up to, within 3 months, up to 75% control, just by having the pharmacist come in and help them titrate medicines and stay on the med adherence. At one of our group provider meetings, I got permission from the board of directors before I did this, of course. I showed up everyone's hypertension control numbers. And at the top of the list was this guy who just started using the pharmacist. And there was a couple others that were really good, really up there. And down at the bottom of the list was one of our cardiologists in 32% control. And he was one of the founders of the group, of course. And he said, "Oh, Dr. Flinn, that's very interesting numbers. I don't think the data is accurate," right? The first thing you say is the data's wrong, right? Oh, geez. And of course, I kind of anticipated this might happen. So I said, "I don't know, Bill, let's take a look." And I flashed his patients up there. We had 90-some patients. And there was the hypertension control numbers. And he's looking up there and he goes, "Well, that patient, that number, that fourth patient right there, that's not mine." I said, "You're probably right. That probably isn't yours. What about the other 96? That's why medical directors last 3 years. So anyhow, he saw that and he grumbled about it. And a couple months later, when Dennis's numbers kept going up and a couple other docs started using the pharmacist, he sidled on down the hallway to Dennis and said, "Hey, Dennis, tell me how this thing works." And he got his numbers. He had most of the difficult patients, of course, but he got his numbers up into the 60% range with the help of the pharmacist. So that's kind of how we encouraged the groups to do that. Here's some of the other stuff that the pharmacist can do. This is also from Kaiser. The use of the combo pill, you can see how the rates go up here, and here's how their hypertension control numbers go up. As they're using the combo pill went up, so did their hypertension control numbers go up. And so you can actually have your pharmacist pull reports and see how many meds someone is on for if they've got hypertension. And they can give that, you can see. An astounding number of people diagnosed with hypertension have 0 meds, or they just have 1. And you're never going to get to anywhere near 80% control if you have that many people that are on 0 or 1 meds. So we recognize at Blue Shield the importance of the pharmacy program and all this. So we credentialed a whole bunch of digital pharmacist providers in 2018, and we now actually have 2 different programs going out. One is we're working with our ACO partners. We actually provided funding for them to hire pharmacists on their care team to directly provide funding for them to employ them and institute these collaborative practice agreements to get things going. The other stuff, because we can't do that with everybody, right? We're not going to buy a pharmacist for every group in California. We've helped to develop community pharmacists and have them develop collaborative practice agreements with groups in the area. So they're using the local pharmacists. To date, we have 25 of these set up throughout California. We're working on expanding that more. So that's another way to leverage this and scale this and get this out there. Rewarding and reporting a registry. As we all know, if you're doing any kind of pop health, you've got to have the data, you've got to have some kind of registry. That provides the feedback for the folks who they have to go after. This was already alluded to earlier today. Again, the number one reason you can use this within the provider community is that provides that data for that peer competition. It's the number one motivator far and away that's sustainable. I already told the story about the 32% cardiologists. Okay, now here's the fun stuff. Does RCI work? You know, is this really worth all the effort and grief and aggravation we're doing? So this is the study that was published about this time last year, and it showed that the heart attack rate, here's the heart attack rate on the left hand side here. The dashed line is California. You can see it's actually being reduced over the years. Here's what happened in San Diego. Look at that. Now, and this is when the RightCare initiative really started in San Diego. Hattie alluded to a lot of stuff that happened earlier to set all the groundwork. And what was that, 2.5, 3 years to set the groundwork to get that thing going, right? Something
We
like
got
that.
the initial NIH grant after we started statewide goals. So statewide goals were set publicly in 2008.
Right.
We got the NIH grant in October 2009. And then we did a lot of pre-meetings with groups like yours in 2010. But our first meeting was February 2011.
Right, so you understand, that's years, right? Years of work to get this going. But once you got this set up and going, look what happened after the UBP started in terms of the heart attack rate in San Diego compared to the rest of the state. Now again, correlation doesn't mean causation, right? There's plenty of folks that know that, right? But it's sure hard to explain why this has happened in San Diego and all other places. the stroke rate did not decrease a lot more differently. It was not statistically significant in San Diego, but you can see it's decreasing across the state altogether, so that's great to see also. The other great thing that happened is this was just published 2 months ago?
September.
September, yeah. Taking that data, this was from up until 2014, right? And so this publication actually continued on through 2016, and it showed that change has continued. So the heart attack rate in San Diego is still persistently lower than it is in the rest of the state. And it does let some attribution of that to what's going on for the RightCare initiative there. So the question really is, okay, so we've been here in the national capital, or the state capital region in LA for a couple of years now. What are we doing different in San Diego that you're not doing here? Why is it different there than it is there? The only thing that we seem to be able to put our finger on that's an obvious difference is that in San Diego they have something where they do a data sharing group, and the groups come together before the meeting and share their data and work on some things, and there's a lot of behind the scenes group-to-group interaction on what's happening. And that may be something that you might want to consider up here as doing for your next step in the evolution of that. Because that's where a lot of the changes really happen, and those medical directors and the groups talking to each other behind the scenes and figuring out, all right, yeah, you know, Joe's doing this, maybe we really ought to try that, because look at his numbers and look at my numbers, that kind of thing.
Another big factor, though, is who is leading. So when you have somebody who is really putting a lot of personal pressure on the medical directors and comparing that data in real time, it's more than just the data.
It's more than just the data, it's interaction amongst the groups as they get in there and start rolling up their sleeves and figuring out how they're really going to work on this. This has to be a priority, this has to be something you believe in doing, and you have to believe that there's a worthwhile effort. And if this graph doesn't show it to you, I don't know what will. Alrighty, so again, in the co-opetition, that's a little phrase we just have for there, because we actually have Sharp and Scripps and Kaiser and the U all sitting in the room together. They leave their knives and guns at the door and walk in and share their stuff. Same thing that you're doing up here. But again, in this informal work group with the data that's sharing it and working on that, it really helps as an informal way to share those best practices and develop that trust amongst the groups. All right, so what does the data show for Blue Shield? We actually kind of look at 8 metrics for RightCare initiative. I know there's 3 that are listed on there: the diabetes control, the hypertension control, and the surrogate lipid control, which, as you all probably know, the AHA-ACC guidelines just came out last Saturday for the new guidelines for lipid control. I have it with me if you want to look at it. It's about 130 pages. It's exciting reading. Not really, but there is some very interesting things in there, both about when you should use a PCSK9, how you have that discussion with your patient on when to start the statins, what level of statins, whether or not you need to use a coronary artery calcium score, those kind of things. So I would recommend looking at that and reading that. There's also new ADA guidelines that came out a month ago that talked about different medications, particularly with the GLP-1s and the SGLT2s. So take a look at that also. But here's the metrics that we look at internally, very similar to what HealthNet was using, including the beta blocker after MI. We just started a work group looking on that also, and that's a very interesting deep dive that we're doing. So when we looked at those metrics, we found that we are not doing as well as we had hoped we were, and that goes along with what Matt had shown earlier. For hypertension control, our numbers actually went down in 2017. So the good thing is we think we know why, because that would be very disappointing if we're doing this effort and not getting anywhere. And the reason why is in 2016 we switched to a new claims database, a completely new claims database. And we spent most of 2017 working on all the kinks in it, including the supplemental data submission. And as you know, hypertension data is supplemental, and our system is completely messed up on that, and we're trying to fix it because we have the same groups that HealthNet does that other groups do. So why in the world would our hypertension control numbers go down magically? And it's got to be the data. And in this case, when you take a look at it, we have one of our primary partners in San Diego, Scripps, whose hypertension control numbers are in the 95th 95th percentile probably nationwide, maybe better, and we have them at 0 and 1% control. So when you see stuff like that, it's like, oh boy, okay, so a lot of work to do on the data. The good thing is, we're hoping the 2018 measurement year data, by the time we get it this time next year, will be a lot better. Now we have many more groups involved in this, and we're working out the kinks on the supplemental data efforts. There was also some other measures that are hybrid measures, and we, again, have to work through all that. Alluded to the work group that's being started for beta blocker after MI. A lot of challenges with that with the data also, and being able to get that MI result to us. As we know, claims processing, the usual bane of the group's existence, 60 to 90 days to get that through. How do we get that in closer? Because you only have a 45-day window for the beta blocker measure to get that in, so we're trying to get that down. And then the clinical best practices, community forums to share the best practices. We have the pharmacy meetings and ACO colloquiums that we're doing to really try to incorporate pharmacists on the care team, and that's meeting some really good success with that, and a lot of the groups are very encouraged by trying that. And the other big thing we did was this best practices self-assessment tool. We garnered all the best practices that we could find from the UBPs, from AMGA measure of pressure down and together goal, from the AMA or the AHA, the Million Hearts campaign. Gene, you alluded to the other one that you're working on also, trying to get all those together. And we came up with a spreadsheet basically. It's about 20 some for hypertension and about 18 for diabetes. And we sit down and we grouped it into leadership, how you do the quality work, patient engagement, provider engagement. And we go through that with the groups and identifies their gaps that they have. So we'll have this list of best practices, and we use a very complicated rating scale. It's either you have it, you don't, or you have some of it. So it's yes, no, or maybe. Very complicated, right? So, and they look through it and they see if they've got the stuff there, where the gaps are, and then they develop an action plan that melds in with a regular quality plan of what they're going to try to fix. And we have some key things that are highlighted as key and essential, including you need to have that registry, right? And you need to get the docs buy-in if you're going to do something like this. It has some resource links embedded. By doing that, it really helps them to focus on what they need to do to get better. And we do the quarterly follow-up. Here's the screenshot of part of the list there, and that stuff on the right on the blue is the links that are embedded that helps them go right to the resource to be able to find that stuff. And what we've learned so far, as you know, if you've seen one group, right? They're all different. Everyone's unique. When they say, yes, I'm unique, we say, yes, you are. So let's figure out how unique you are and what we can do to get you going toward that 90th percentile. We also emphasize that the RightCare initiative work does synergize with a lot of other quality efforts going on. This isn't something that's out there all alone and unafraid. And you know, when you think about it as a primary care doc, what is more basic than me treating hypertension and diabetes? How much more basic can this get than trying to get that? And it does have meaningful outcomes and can make a meaningful outcome in the short term. And that's what we really try to emphasize to the partners. We also give them clinical assistance, quality expertise. We're cleaning up our data, trying to get things better. And we know that for our partners on the ACO-wise, they'll get better incentives in terms of dollars returned with the way we have our contract set up, and also for the P4P participants. Next, we're going to continue to scale the work. Again, we have 28 to date. We're on glide slope for 40 by mid next year. Our mandate was to report this out. Final report is due in February, but we have at least a 5-year engagement plan with this, so we're not giving up even when the mandate's done. We're going to keep going because our goal is to reach the 90th percentile on those metrics and provide that care that our members are deserving of. Any questions? Yes, sir.
I've always puzzled over the difference between Sacramento and Southern California and other areas. And particularly since Kaiser has a huge presence in Sacramento. And we know they do well. Most of our groups do pretty well up here. I actually think I may have hit on something a little bit when I was looking at we moved into the Bay Area as well. If you take a look by county at obesity rates, there's some huge differences. And then you start taking a look at smoking rates.
and it's very different. I mean, San Francisco and Marin have about a 10-11% obesity rate, it's twice that here. I haven't really studied much San Diego and some of those others. It's clear San Diego, the trend, it has gone down, and so what's gone down effectively. But when you're comparing region to region, that's something to keep in mind. Actually, San Joaquin County's obesity rate is 10 percentage points higher than Sacramento.
I would
It makes a big difference.
Thanks for pointing out, and that's a point I didn't emphasize on this enough. When I'm talking about next steps, I don't even think I need to put this in the slide for the next presentation. No, I don't have it in there. When you're talking about things like that and getting folks, how do you attack the obesity rate? How do you attack the inactivity? It's not just through partnering with provider organizations. It's got to be more than that. There's got to be some community effort. How do you make it easier for folks to get out and exercise, feel safe when they do it? Not like they're taking their lives at risk to step outside their door. How do you provide the food deserts, right? How do you provide the healthy alternatives for that? How do you break that cycle? And that's part of what we are certainly looking at going forward, both from a leadership perspective of how do we really improve that, because we have to fix. If you've got a group that's at 30% control, you're never going to get to 90% unless you fix that 30%, right? So we know there are hotspots we have to do it, and we know we can't do it alone. And there's a lot of that stuff we talk about you all probably heard this already, right? Your zip code may be more important than your genetic code. And so how do you fix the zip code issue? Because I'm not going to fix a genetic code issue, and it's not just beat people over the head with medicine. It's how do you get them active? Bob Salas from Kaiser, did he give his talk up here?
We've not brought him up here.
As exercise is medicine, excellent thought. And it may be as important a factor as smoking or hypertension in terms of risk factor for cardiovascular disease. So how do you make that happen and engender yourself in the local community to make that happen? Very important. Thanks for bringing that up.
We are going to do a session on smoking cessation though.
Yes, exactly. So January 14th is our next program right here. We're missing one in December, and January 14th with Dr. Kahatsu will be about smoking. So look forward to that. Any other questions for Dr. Flinn? Yes.
Can I just make a comment? Because I had the great pleasure of being able to team up with Dr. Flinn in San Diego for quite some time. When this whole thing started in San Diego, the medical groups didn't want to be in the room. They weren't thrilled about being in the room. They all were in there and they were quiet. And it was like, you could hear them pin drop. Dr. Demariak said we're leaving all the weapons at the door and we're coming in here to work on community health together. And you could start to see those changes. And when we got down the road, we knew that we needed more, and so that's how we started talking about data and getting the data. The data's where it really changed, like you said. It really changed when groups got together privately before the meeting, and they started to talk about data that really was real time. And when you started to look at what was really happening in the real time, in the real office, that's when it was like, oh my gosh, this is what we need to do. And that's how that got started. And I think you guys could do that here. There's no reason why we couldn't do that here. And that would really start to make a change. So I just wanted to comment, thanks you for being here.
Thanks, Liz.
Great, thanks, Liz. Dr. Ivy, you mentioned, and I said nothing was happening in December, but there is something happening in December, a webinar, is that right?
Yeah.
Tell us more about what's the date on that.
We're going to do a webinar. Is Bob still here?
Can you give it a mic? He just walked out. Yeah.
Is Bob Thurman still here?
He just had to leave.
So I don't have my little calendar sitting here.
Is it on?
I don't know.
Yes, it is.
It's great. But we are having with CDPH a webinar in December.
We'll be sending out the
We'll
link.
send out the
with
link and the
date,
dates
et
to-
cetera,
But
but
it will be
Right.
giving an update and some deep background on the high-risk group, South Asians and cardiovascular disease. And that will have me speaking, but also Dr. Alka Kanaya from UCSF, who's the PI of the Masala study, which is the first longitudinal cohort study that parallels MESA to look at cardiovascular disease and cardiovascular risk factors and diabetes on South Asians in the U.S., both in California and in Chicago.
Okay.
So we'll have, a workshop on that, the 10th.
December 10th,
December 10th.
cardiovascular risk in Southeast Asians, South Asians.
Asian, Indian,
Asian, okay.
Pakistani.
So that's coming forward. You'll get an email about that. We're looking forward to that. I just want to ensure that we give a great round of applause to all our speakers. Dr. Flinn, thank you. I think, in summarizing this, we've heard a lot about different protocols that get pulled in. We talked about engaging with people. That's what this is all about, and that's what you are here to. We engage with you, and we engage with each other, but then we've got a lot of people out around us that we need to engage with, and as leaders in this fight, spend some time and determine how we can get that big bang for our buck. And engage with people, and we talked about engaging with individuals, and it's everybody has a different need, and as we work hard on this, I think we'll continue to make some progress. There's a CME for those who, if you have this on your table, you can fill this out to get the 12 to 2 p.m. CME. So go ahead and please fill out the survey and hand it to Brian or Megan or Kathy, and big round of applause to Brian, Megan, and Kathy, who they pulled things together and got Bill Ballmer on the line. Bill, are you still there? Maybe not. But thanks for all your work. And
yes, I am.
Oh.
Congratulations on a great program. I think it gave us a lot of ideas of where to go, and I think there's a lot of there and a great interest in trying to achieve these goals, and I think we've got to succeed one way or another.
Thank you, Bill, and happy Thanksgiving week, everyone. Thank you